Just
Share it.
open now.
Because I want the video and I can't.
No, it's not
No.
showing.
No.
Please share your screen first, Reshma.
Okay. So when I share, is it for the presentation, right?
Yeah, it's coming.
Yeah, but I guess I don't know why my video is playing up.
It's not playing.
Yes, it's there.
Yes, it is there.
It is there. Okay, great.
This
Yeah,
is this is the PPT.
Yeah.
Yeah.
You can
Scroll it.
do you have the videos?
Slideshow, you'll have to make it into slideshow.
Yeah, that is fine.
Yeah.
That's okay. I think I'm the second one on the list, right? So
I
Yes.
need to check first.
Yeah.
yeah.
I'll do it.
There is some gray strip at the top.
Yeah, it's there at the side.
Yeah, this is visible.
Are you able to see my screen?
Yes,
Yes, yes.
Full screen?
Yeah.
Yes, full
And the
screen.
slides are running? The
Yes.
video
Yeah.
is seen?
Sunny,
Yeah.
yes.
Perfect. Should I unshare for now?
Yes.
Please.
Thank you.
We'll start at 6:35. People actually join after 6:30.
Hello, Avinash sir.
Is Raj-
Hello. Good evening, everybody.
Good evening.
Good evening, sir.
Good evening.
Evening.
Hello, Nikita, Shilpa.
Hello, ma'am.
People interested in patient safety. Hi, Sheetal.
Hello,
madam. How are you? Very nice topic.
Yes, actually, it's a good topic. I wish more and more people should attend. Let us see.
Yeah,
The
they will,
topic
they will,
and the
don't worry.
speakers both, madam.
Good
Yes.
evening, madam. Good evening, all.
Good evening. Good evening, sir. Good evening, Sheetal ma'am, Shilpa, Nikita madam.
So I saw a notification. Do we run this parallelly on some other platform also? Apart from the webinar? Does it go
Yeah.
live?
YouTube.
YouTube.
Yes.
Okay.
And later on, it is uploaded on the YouTube.
Okay. But probably live also because there was a notification that said that more than one apps it's going to be shared. So
Yes. So
Yes,
if we
yes.
have more than
Live
100
on YouTube.
participants, I think it goes to YouTube.
It is
Okay.
live on YouTube now also, and then recording also will be available.
Excellent.
So the Zoom
I think I say
topic-
Maharashtra state is doing an incredible job. Congratulations to all of you.
Thank you, ma'am.
6:35.
Yes. I think we should start. Rajesh?
Yes, yeah.
Good evening. Good evening, Dr. Anita Nikina, Dr. Avinash Bhopte, sir, Dr. Vibha Palera, ma'am, and Reshma Ambulgekar, madam. And today, our chairperson Rajendra Patel, sir, and Jitin Bapat, sir. This webinar series was started from last October 2024 under the heading of Safe Anesthesia and Saves Life. This is seventh webinar from from the SAM. I would like to request Dr. Anita Neti ma'am to brief about this seminar.
Thank you, Rajesh. So I welcome you all for this SAM symposium and for a very important topic, that is safe anesthesia practices inside the OT. And generally, we tend to think as clinicians that it is good. It's good to know the skill sets that we have. If your patient is crashing, if your patient is arresting, then you need skills for CPR, for intubations. But it doesn't occur to us, and recently it's been pointed more and more at more and more platforms, that the non-technical skills like the leadership qualities, the communication, the situational awareness, these qualities are in fact more important for the success in a critical situation. So let us know from our eminent speakers, Dr. Vibha, that how actually these are more important. It's been shown time and again, there is research on this, that the non-technical skills are more important than they were previously thought. And also another topic, again, non-clinical topic is there, the WHO surgical safety checklist. We just tend to feel it as a routine and it is not taken in that sense. How many of us do a surgical safety checklist as it is to be done, the sign in, the sign out properly? So let us know from Dr. Reshma. And we have two eminent chairpersons, Dr. Rajendra Patil sir and Dr. Jitendra Bapat sir, who will guide us about this topic. So I request Dr. Saurabh to introduce our first chairperson, Dr. Rajendra Patil sir.
Good evening, everyone.
Yeah.
I have the honor to introduce Dr. Rajendra Patil, sir. He is a consultant anesthesiologist and ex-HOD at Ruby Hall Clinic, Pune. Pretty long experience of anesthesia practice, more than 36 years. He is a medical simulation educator, has a special interest, obviously, in simulation in healthcare, inhalation anesthesia, and low flow anesthesia. He conducts workshops at state and national platforms on low flow simulation in various anesthesia type like obstetric, pediatric, difficult airway. He's a past president of Pune ISA branch and organizing chairman of various conferences, including Pune Maharashtra State Conference. Welcome, Rajendra Patil.
Thank you.
Good evening, everyone, and welcome to today's SAM's webinar. It's my pleasure to introduce our esteemed moderator and a dear friend, mentor, and a senior from JJ Hospital, Dr. Jitendra Bapat, who is a senior consultant anesthesiologist at PD Hinduja Hospital, Mahim, Mumbai. With over 28 years of experience in the field of anesthesia, Dr. Bapat is a highly respected expert. He has served as a past president of Indian Society of Anesthesiology, ISA Mumbai, and has received specialty training in rescue medicine, liver transplant anesthesia, and transesophageal echocardiography from renowned institutions in Germany and UK. Dr. Bapat holds an additional qualification in Diploma in Medical Legal System and an MBA in Hospital Management from BITS Pilani. His expertise are in clinical anesthesia, education, and healthcare management. Please join me in welcoming Dr. Bapat, who will share his insights and expertise with us today. Thank you.
Now I have the privilege to introduce Dr. Vibha Naik, who is a close friend. And at such a young age, she has got so many accolades to her credit. She's a senior consultant onco-anesthesiologist and working at Basavatarakam Indo-American Cancer Hospital at present at Hyderabad. And her areas of interest are onco-anesthesia, pediatric anesthesia, and vascular access. And she has been a speaker at various national and international forums and has more than 50 publications and 10 book chapters to her credit. She's an associate editor of Understanding Pediatric Anesthesia by Dr. Rebecca Madam. She's an associate editor of JOAPM and assistant editor of JOACP and reviewer of multiple international and national journals. She has been awarded the IPA Pediatric Anesthesia Fellowship and SOPSI Onco-Anesthesia Fellowship. She is the past secretary of Asian Society of Pediatric Anesthesia and very active in Indian Association of Pediatric Anesthesia. She's associated with Smile Train for more than 18 years, and she is a faculty for IC and SOPSI accredited Onco-Anesthesia Fellowship and FNB Onco-Anesthesia. Please welcome Dr. Vibha Naik.
Thank you so much, Dr. Anita. Being here on this platform today is indeed a privilege for me. It's almost like homecoming because I belong to the state. For those of you who do not know, I did my MBBS as well as MD anesthesia from BJ Medical College, Pune.
To interrupt, Vibha, we'll finish with the introduction of Dr. Reshma.
Okay, sorry.
I'm sorry. Ganesh, please share Dr. Reshma's CV slide.
Hello, I'm Dr. Rajesh. I am very happy to introduce Dr. Reshma Ambulkar ma'am. Coincidentally, she is from my same college, Grand Medical College, and she did MBBS and MD from Grand Medical College, Mumbai. She has been fellow of Royal College of Anesthesiology, that is, she has done FRCA from London. Presently, she is a professor and head of the Department of Anesthesiology, Critical Care and Pain at Tata Memorial Center, Mumbai. She is a secretary of Society of Onco-Anesthesia and Perioperative Care, Mumbai branch. She is a life box anesthesia advisor, Southeast Asia, and areas of special interest are difficult airway management, patient safety anesthesia for GI surgery, and hospital administration. She has over 70 publications. So I welcome Dr. Reshma ma'am.
Yes, Dr.
Thank you, Rajesh.
Yes, Reshma, welcome. And I request Dr. Vibha Naik to start with her presentation.
So, thank you so much for the lovely introduction. And as I was saying, that it's indeed my pleasure to be here today and talking on a topic that's extremely important, as Dr. Anita said, that is being discussed more and more these days, and that's non-technical skills for the anesthesiologist. My session is going to be interactive, and I would really like for the questions that I ask, if the attendees post in their answers. And I'm also going to keep troubling my moderators, Dr. Rajendra as well as Bapat sir, to keep asking questions so that the session stays interactive. Now, let me begin with an example. Let us assume that you are driving to a new place with a friend and say 2-3 children in the back seat of the car. Now, because this is a new place, you have put your Google navigation on. Yes, you expect some challenges that you're going to that area for the first time. So it's going to be an unfamiliar area. Your friend has opted to put in the radio music very loudly and enjoying his favorite song. You're slightly confused with direction while children are demanding your attention. Now, in such a scenario, though you are very well skilled to drive a car, you've been doing it for umpty number of years, and you also know how to use the Google Map navigation well. But unless you are watchful of the signposts, unless you ask your friend to shut down that radio if it's distracting you, if you request your friend to double check the navigation for you and you know when to prioritize between children and the situation, if you're able to do that well, you will avoid a major problem. And if you are not able to do it well, you could actually either lose your direction or end up in a crash. So this is an example of how non-technical skills, even though you have technical skills, non-technical skills are important. And if I have to sum it into a definition, I would call it as a constellation of, and each word in this definition I feel is important. It's a constellation of both cognitive as well as social skills, which can be exhibited not just by individual, but also by the teams to reduce error and improve human performance in complex systems. Now, all of us know that the knowledge and understanding of non-technical skills for us has come through the aviation industry. But I could not miss but talk about this incident, which is the Tenerife airport disaster, which actually was the cause for starting the concept of non-technical skills in the aviation industry. And this unfortunate incident in 1977 occurred because of poor communication between the pilots of two airlines, the KLM Dutch Airlines, as well as the Pan Am, which is the American airline. And the communication between the pilots and the air traffic control caused this mishap. And this was the reason for the airline industry to start considering non-technical skills as the crew resource management. Like you would agree that anesthesiology can be associated with certain dynamic situations. Operating room is a complex environment with a lot of monitors, tubings, different types of personnel working there together. Anesthesia involves the use of potentially dangerous drugs, and we are aware that the critical incidents can occur during anesthesia. However, what's interesting to note is that 80% of these errors are attributed to human factors, which showcase lack of non-technical skills, and hence the importance of this topic here today. Now, around 20 years later, somewhere in 1990s, the University of Aberdeen and Scottish Clinical Simulation Centre came together to formulate this framework of anesthesia non-technical skills, popularly called as ANS. And I'm sure most of you have had a look at it, but in case someone does not have the handbook, I've put up a QR code that you can scan or take a snapshot at this point of time and go back to the handbook for a detailed reading later on. So this AND system composed of 4 discrete areas: task management, teamwork, situation awareness, and decision making. And we are going to delve into each of these components soon. However, what I wanted to highlight here is, while I go through it, many of you may feel that, all this is common sense. But unfortunately, common sense is not that common. And it's important to make the implicit explicit and talk about it so that we are better at performing it when it's required the most. So far we've discussed that non-technicals, we've looked at the definition and we've learned that they are important in anesthesia. So now I'm going to give you a case scenario. And I would request, as I said, all of you to help chip in answers so that it will be more interactive. Now, a nurse from a ward has called saying that the child looks unresponsive. You are on an emergency call duty and you've been asked to attend the call. You are presently doing a PAC because you're on emergency call duty. The next case that is going to be scheduled is a patient with intestinal obstruction for emergency laparotomy, and you're doing PAC of this patient. You're almost finishing. You're counseling the patient, counseling the family regarding the surgical procedure. And you get this call. So what would you want to do? Can you please put in your answers? And Rajendra sir, may I disturb you in the meantime? What do you think you would want to do? You may have to, sorry sir, you may have to unmute yourself. Sorry.
Yeah.
Yeah, please.
Yeah, so first thing I would do is call for help.
Sure.
Right?
Yeah, absolutely. So you want to call for help for the child or for the PSE? I'm so sorry.
For the child. for
Yeah,
the
that's
child.
right. That's right. So I think I've got some answers over in the chat box that to attend the call, rescue the child, part of Code Blue, excuse yourself and go and attend the responsive child. Absolutely. Ask the nurse to put the monitor and give oxygen till the time you reach. Absolutely right. So thank you everyone for the answers. It's important to prioritize at this point of time. I completely agree with you. Anyone else that you would want to come or any more equipment that you would want to fetch? May I request Bapat sir to chip in here? Bapat sir? I'm sorry, Bap. Okay. No. I think you all need to unmute yourself. I see Anita speaking. I see Bapat sir. Yeah, please. Yeah.
Am I audible? Yeah.
Yeah.
It goes without saying how Rajendra has said that you have to prioritize, and the unresponsive child warrants your attention first. And till you reach the scenario, you can put your PAC on hold, ask for the help, and someone if you have the systems to generate code blue or whatever the code what you are instituting, uh, start that, and so all the necessary help along with the equipments reaches the destination. I think that's
That's
the
right.
most important thing. Yeah.
Absolutely. I completely agree with you that if you have a system to activate the system. Otherwise, you can ask someone to come and also someone to get the equipment. Okay, so let's just talk about prioritizing here. Now, let me just give you an example. At this point of time, you possibly have 4 things in front of you. 1, to go to the ward to resuscitate the child. 2nd, to hand over the PAC case to a colleague because that patient is going to go for surgery and you don't know how much time you would take there for resuscitation. 3rd is to bring video laryngoscope and pediatric bougie from the OT because you know that it may not be available in the ward there. And 4th is to read the ping that you just heard of your friend's reply to your Facebook post. So I'm going to ask Bapat sir again. Sir, how would you want to prioritize these 4 tasks?
I think going to the ward to resuscitate the child is the priority. Unless and until you have seen that child, what is the status, what are the vitals, what is the state, you don't know what kind of help you will require. So rather than mobilizing sometimes it could be a false alarm also. You never know what child may be sleeping. Yeah, it happens many times. If you really do audit of your audit views and RRT's page, sometimes they are the false alarms. So it's very important. You have to be present on the spot and then to assess. I think that's a prioritization. And then you take your own further decisions, what you need.
That's right. But how about the others? Is there any sequence to the thought process of the tasks that you need to do?
Well,
I agree that 1, everyone has said, even the chat box says 1. I agree, 1 is the first. Sorry, go ahead, sir, please. I interrupted.
Yeah, I would prioritize in following order. Patient, staff, system, immediate, intermediate, long term. Some will be pertaining to this case management alone, as in the present tense. But if the nurse on the ward calls anesthetist in the other part of the hospital without the ward RMO, something needs to be done with the system, but that is for the long term.
I completely agree.
Immediately, as my colleagues have said, first priority is to the patient, ABC, call for help, oxygen. That is what we are trained to do. While we assess and when sufficient, relevant specialties are present, reassess and take it from there.
So, thank you so much, Dr. Sugam, for answering this. While whatever I think all of you said is important, one aspect that I wanted to highlight here is that when you have multiple tasks in front of you and you need to prioritize, the Eisenhower decision matrix comes pretty much handy. And it is dependent on 2 aspects: whether the task is urgent or not urgent, And second, whether it is important that you have to do it or it is not important for you to do it. Okay, so let us just take examples. Now, like we all agreed that resuscitating this child is both urgent and important, and you have to do it as the first thing. The next important thing is handing over the PSC case to a colleague. Now, this, because you have done the PSC, it is important that you do it, but it is not very urgent. Probably it can wait for 10, 15, 20 minutes. It may be fine. And if there is a time when it comes, maybe that someone else who's waiting for that is going to reach to you. Okay. So this could be decide, meaning you can decide to schedule a time. It is important, but it is not urgent. Getting VLS and pediatric bougie, say from OT, because you'll require it for this resuscitation, is urgent. But it is not important that you need to do it, and hence it can be delegated to someone else. And finally, like all of us will agree, that reading that Facebook ping reply is not very important, as well as not urgent, and needs to be deleted out of the task for the time being. So I just wanted to highlight the prioritization matrix and how it can be used when we have too many things at a time that need to be done. Like I think Rajendra sir just mentioned, that if you have a system in place, also I think I saw a message chat posted in the chat box. If you have a system in place, the systems come in handy. So want to highlight here for all those of you who do not have existing systems, and I know that there are many hospitals that do not have emergency systems. I think it's time that you think to have some form of emergency activation system and some standardization of supplies in terms of crash cards that need to be available, which are exactly similar in different parts of the hospital, which are labeled so that it's easier to find which part goes where. Also important, like I've shown our crash card, it needs to have a cover and it needs to be zipped down and kept closed so that no one is able to use any of that equipment from that crash card in between, so that you do not find an incomplete crash card during an emergency. And the crash card has to be opened only and only during code blue calls. So this was about preparedness of the task management. And the third aspect of task management is planning. Even if you have preparedness, planning is specific to the event, and depending on what the case, what the crisis is, you would possibly need to decide whether you need more people also who will do what, that we'll talk about a little later in teamwork. Also, any specific equipment that would be required for the crisis, and identifying what you would need and how are you going to utilize the resources. Okay, now I have a small video for all of you. This video was prepared by one of my friend, Dr. Murli, just for academic purposes, but to reflect a case scenario in a hospital which does not have a code blue activating system. So please look at the video carefully, and we'll probably look at what went well and what was challenging.
Nurse, what happened?
Just want to confirm that you are able to hear, right? Whatever they are speaking?
Yes, yes.
Are you able? Oh, perfect. That's right. Thank you so much.
Nurse, you stay outside. Sister, what happened? Baby is unresponsive. Call the doctor. Okay.
What happened?
Baby was
Did the
all
patient
right.
vomit?
Baby was all right, but suddenly became unresponsive.
What happened? Pulse. I can't feel the pulse. Baby is not breathing. Take mask, shampoo bag, and ET tube and everything. Sister, what happened? Why it is taking so much time? This is not appropriate. It is inappropriate. Take the correct size. Please, one of you bring the ECG leads and SpO2 monitor.
Doctor, ECG leads.
You don't know how to connect. Sister, load adrenaline. Sister, where is adrenaline?
Doctor, whether should I dilute it or not?
You are good for nothing. Just leave.
So I apologize for the soothing music that went on that could have just interfered with your understanding of what was going on. But what I would want all of you to think about is what was challenging, meaning what could have been done better. And in the meantime, let me just quickly take you through what I think went well. Okay. So I think they did identify that there was some problem. They did call for help, and there were enough people available to resuscitate this child. So, who wants to do it? Anita, would you want to tell us what was challenging or what could have been done differently?
Yes, there was no leader, identifiable leader, and 2-3 people were instructing, so people were getting confused. Like you need one leader who will tell, delegate the things. So there was
That's right.
something of leader.
Yeah, that's right. Anyone else? One more. I'll just take one more opinion and then we'll move on.
Yeah, this is basically, the first thing is the exchanging the information. Okay. And we need to know who is capable of doing what, right?
Absolutely.
But they were asking for, mask. The mask was not fitting well, and they asked for something else, which was so. Basically, if you have somebody who knows the environment, who knows the resources, then that will be more helpful.
Wonderful.
Yeah, sorry.
No.
Yeah.
Go ahead, sir.
Yeah. At the same time, as Dr. Anita said, if you got somebody who is in sort of in command or in leadership position, he can just have a good view, and then he can direct all the members to basically coordinate.
Yeah, that's right. And I also like the answers put up in the chat box. No leadership, role allocation, do not criticize, no closed loop communication, criticism. So thank you everyone for answering. And I think we've pretty much spoken about everything. So I think there was the communication with the parent was not really good. They just said, okay, you go outside. But apart from that, the equipment organization was poor. It was a little chaotic as we could see it. Though there were people and all of them were probably wanting to help. Everyone wanted to do something for the child, but there was no organization of the work, and the communication within the team was definitely unpleasant. So with this, I'm going to use the opportunity to talk about the second aspect of ANDS, and that is teamwork. Like everyone said, there has to be a team leader. Any crisis situation, whether explicit, that someone says, okay, I'm going to lead, or many a times it could be implicit. Like maybe if Anita is in a crisis in her OT, everyone knows she's the leader, right? But what is important that as a team leader that you allocate roles to team members, and this is a typical team organization during Code Blue. I'm sure we all know about where the airway person should stand, the compressor, the one who loads drugs. The team lead needs to stand at the foot end so that they can have a good bird's eye view. But I wanted to highlight one important thing that we often miss while we are dealing with such crisis situations is to have someone who is documenting at that time and timekeeping. And this is important because it is this person who is going to create situation awareness for the entire team. That this person is going to keep a track of what is happening, in what timeline, and is going to give us inputs. And hence, this person is very, very important. Leader, as much as possible, should delegate the tasks and himself or herself remain hands-free to be able to supervise and overlook. Now, while I'm saying this, I'm sure Rajendra sir is thinking that, but what if the leader needs to perform a critical task? It's a small child. The child requires intubation. Who else but a trained anesthesiologist to do it? Isn't it, Rajendra sir? What do you think? If the leader needs to perform a critical task, how do we go about?
Well, he can pass on the responsibility to somebody else, right? If he needs to do that particular task. Yeah.
Absolutely right, sir. So it's important that you designate the leadership. And that means that while you just tell one responsible team member that while I'm intubating, I want you to go and stand at the foot end and watch the monitor above my head or wherever it is, and Tell me if there is, say, X, Y, and Z, so that you give them clear instructions what to do as a leader while you complete a task. Now, it's important to talk about some other aspects of team dynamics at this point of time. And the first and foremost is clear roles as per the competency. I think we just discussed about it. When you think that the nurse may not be able to do something, you need not give her that role. You can give it to someone else who can do it. The second thing that someone just mentioned some time back is clear messages. You know, the doctor in the video says, can you load some adrenaline? It's such a non-specific message. Your message should be one, who are you wanting them to load? Second, how much adrenaline or in what dilution do you want them to load? And also important is a closed loop communication, meaning after you've completed the instruction, the person should reply that they have to acknowledge, okay, I will load adrenaline as you have asked or whatever. Once they load the adrenaline, I am ready with the adrenaline in whatever dose that was asked. So it's important to close the loop to know that things are proceeding. Another important aspect that was highlighted in the chat box earlier is not to use disrespectful words. And we all know that it actually inhibits the team members from coming forward either to take up responsibilities or be more helpful if you are shouting at them or using disrespectful words. Constructive intervention is extremely important. However, this should come with objectivity, meaning using a specific aspect to give in the suggestion makes it more pleasant. And we'll talk about it a little later in the next scenario that we discuss. And finally, but also very, very important, is that every crisis, once the crisis is over, maybe the patient is doing well, we all are happy, and then we just move around. No. It's important that we debrief, reflect through the thought process of what went in the scenario, and come out with learning points that will be useful in the next scenario. My personal opinion is that as a good leader in a crisis situation, leaders help bring calm to chaos, clarity to confusion, and courage to uncertainty. So these are the goals that a leader should aspire to become. Another important aspect of being a leader is to share the mental model, which means that whatever is in your mind, if you read it aloud, it becomes easier for your team members. So suppose you have decided as a team leader to designate the leadership to someone else and go and intubate the child. While you put in your laryngoscope, if you are not able to see anything, before you just start taking pressure or try to fiddle, trying to intubate, it's important to verbalize the situation, like saying that, oh, this looks like a difficult intubation. And I would next want whatever, whether you want the video laryngoscope or you've already used video laryngoscope and now you want the bougie. So it's important to verbalize the situation, announce the difficulty that you are anticipating, and also mention the plan that you have in mind so that your team will better understand what is going on in your mind. They can predict the needs of the task and also assist you well. And this is important, I feel, because when we share our mental model, we multiply our brains and not just our hands. Now, here's another video for all of you. And I think we will do the same. Once the video is over, we'll talk about what went well and what was challenging. This video does not have audio. So this video is something which comes from the Elaine Bromley case. Way back in 2005, a young woman, Elaine, was taken up for a nasal endoscopy surgery. And the clinical team that was taking care of this patient had a very experienced surgeon, experienced anesthesiologist, an experienced technician, and nurses. The level of staffing and skill in the hospital was good. The availability of difficult airway equipment, including the fiber optic bronchoscopy, was there. But while she was taken up for surgery with normal vitals, after they gave some propofol, they realized that it was difficult. She was tight and it was difficult to insert the laryngeal mask airway, which was their first plan. So they decided to paralyze her, after which she started desaturating. Her saturations gradually felt significantly low when the anesthetist decided to go ahead and perform the tracheal intubation, which of course was difficult, and they landed in can't intubate, can't ventilate situation. The nurse in the OT actually said that there is a tracheostomy kit, but her suggestion was overlooked. And after 20 minutes of hypoxia, even though they could get back her vitals, hemodynamics, she suffered significant brain damage and succumbed 10 days later. Sorry. So I'm sure many of you have heard about this case, but I wanted to use this scenario to highlight certain points in ANS. And again, like before, I would request you all to think about what was challenging in this case while I quickly take you through what went well. I think the team was definitely experienced and skilled. There was availability of difficult airway equipment. The primary anesthesiologist did call for help. The other anesthesiologist came in. The surgeon was definitely there. But yet the outcome was not good. So now let's talk about what was challenging. So who wants to take that? I can see some answers coming in, but if someone can verbalize here.
Can I comment, Viva?
Yeah, sir, please go ahead.
Well, in that scenario, the most challenging and overlooked task was oxygenation. And oxygenation is always a priority over the intubation. And I would like to share a nice quote from one book, which says that in a difficult intubation scenarios, the multiple attempts are made by the ascending level of seniority, which is proportional to the ascending level of their egos. And perfectly the same thing happened in this case, I suppose. And the oxygenation at any point of time was overlooked, and they were only concentrating on intubating. That is the first thing which went wrong. And they never listened to the suggestion given by the nurse. Her advice was not taken into consideration of an early front of neck access. They thought that they will succeed in passing tube some way or the other, where they went wrong.
Absolutely. Thank you so much. And I think we've got wonderful answers in the chat box too. Situational awareness was not there. They were not mentally prepared for a difficult airway. There was fixation bias. I really like that word. Valuable time was lost. Change of hands could have helped. There was change of hands, though I did not mention here, but the real case, there was change of hands. The nurse was not empowered, a very important aspect, and front of neck access could have been tried. And I completely agree to all of your suggestions. Like, first and foremost, they did not understand the severity or gravity of the situation. They lost situation awareness. There was a fixation error. The decision making wasn't as good, and there was a lot of hierarchy, that they did not listen to the nurse's suggestions. Now, let's just talk about fixation error here. What is fixation error? Fixation error is a state of cognitive lockup, wherein once you start concentrating on one task, that's all that you can think about, and you lose relevance of everything that's happening around you. Fixation error can be of three types. Positive fixation, when you believe that only and only this is the most important thing right now. Negative fixation, wherein you're trying to rule out differentials of a situation, say, and you think that it could be anything but this. And denial fixation, which I feel is the worst, where when something is going wrong, you still think that all is well and you are in control. But the important aspect is for us to think, why do we fixate? I'm sure it can happen to any one of us. So it's important to dwell upon, why do we fixate? And literature has shown that the most common reasons are prior experiences, meaning I think it's very easy for us in today's time, when we have difficult airway algorithms and multiple times through lectures, webinars, workshops, we've emphasized the importance of oxygenation. But let's take it back to that time, 2005, where probably all this was not there. They don't have enough bombardment of this concept that ventilation and oxygenation is more important than intubation. And these sometimes are very, very important in having fixation error. Also, in a stressful situation, as I said, you can just go into a blank or a cognitive lockup situation and lack of situational awareness, which I'll talk about in the next slide. Now, for this, let's just switch a little bit and take another case scenario, which is that the anesthesiologist has given spinal, just say 10 minutes back, and the BP has cycled to 80/50. Now, if we were to talk about the situational awareness of the anesthesiologist, it can occur at 3 levels. The first is perception, which means the anesthetist is able to recognize that there is hypotension and is not busy on social media on the phone. Second is comprehension, meaning having recognized that this is a problem situation, the anesthetist starts treating it, but it is inappropriate if the anesthetist does not start considering the differentials after the initial management. So initial management, yes, to give fluid bolus, but also important is to consider differential and start ruling in or ruling out the possible differentials. And the last step is also very, very important in situational awareness, and that is the projection, which means to understand the severity of the situation, to voice out, inform the surgeon, ask for help so that you're able to handle the situation well. Now, let's talk about, so let me ask you, how would you think we can improve our situational awareness? And while I ask you to put these answers in the chat box, I'm going to take you through what are the threats for situational awareness. So the threats, as all of you would agree, is that there are a lot of distractions in the OR, including irrelevant conversations, mobile phones, social media, maybe sometimes loud music, or maybe irrelevant alarms. Sometimes we are tired, so fatigue and stress can also create a threat to our situational awareness, and of course, task fixation that we previously saw. Now, let's talk about how do we improve our situational awareness. So may I request someone to volunteer to answer this? Dr. Sugam, do you want to take this? How can we,
Yeah, I will. So can I go on the skeleton, like distractions in the OR, including that part? Yeah, it is.
Sure.
Once again, can be broken down into the people in the operation theater and the equipment in the operation theater and the outside factors which keep coming in and out of the operation theater. So people in the operation theater should be focused primarily on patient care and not in sending WhatsApp messages. At the same time, if the patient has got a regional anesthesia and if the surgeon has said, oh, just give him some sedation and you are giving 2 milligrams of midazolam, only for the surgeon to put loud stereo disco music. What that midazolam does, no one knows. So that becomes a part of situational awareness on the surgeon's part. So all the staff should basically be on the same page and work together for the patient in the center of their spectrum or sphere of expertise.
Yeah. Thank you. And I also see some good answers here. Constant vigilance, mock drills, and verbalize the problem to all those interested in the present in the OT, I would want to say. Yeah, in the OT. Okay, right. I agree. So a few ways that we can improve the situational awareness. First is the sterile cockpit rule, and I'll just come to it in my next slide. As someone said, constant vigilance, having a systematic approach to periodically scan the things in the OT. You can maybe start with the monitor, then the patient, then the surgical field, and then to even other people who are in the OT to see who is doing what. And then keep repeating this periodic scan. Definitely inputs from the team, like someone just suggested, is important. I also wanted to say that we should not bias the team members with our perspective. And this is in relevance to when someone else comes to help us. When someone else comes to help us in a crisis situation, most commonly what we end up doing while we are sharing the narrative of what happened is what we think is the cause, So just share the sequence of events and do not give explanations to why you think what has happened, because it might bias the person who has come to help you, and unnecessarily all of you again go on the same page rather than having a different perspective. Also, to improve situational awareness, there are some games like mindfulness games and observational games, which I leave to the Q&A session if at all we have some time there. But let me talk about one important aspect, and that is the sterile cockpit rule. Again, this comes from the aviation industry. Like you all know that whenever the flight takes off and lands, they prohibit all the non-essential activities. Similarly, in the operating room, during induction, during emergence, and in any crisis situation that you may think is evolving, you need to follow sterile cockpit rule, which means that you have to prohibit all non-essential activities, including the music. Another important aspect that was highlighted in the previous case was hierarchy, and it's important that we talk this because this is very, very prevalent. So let me put this as the power distance index. This means that the doctors, or maybe I don't know, maybe in some scenarios it's the surgeon and the anesthesiologist and the nurses and the ward boys, or maybe the doctors are at one level and the rest of them are at the other level. But it's very, very common in Indian scenario to have some power distance, which actually is inhibitory for getting the team inputs. Now, let's go back to that scenario. How do you think the nurse in the OR who was ready with a tracheostomy set, how could she have communicated to overcome the hierarchy? So I would request you all to put it in the chat box, as well as let me see who wants to answer this. Anyone wants to? Bapat sir? Or maybe Anita? Anita, you've unmuted. Go ahead.
Yeah. So actually, the nurse, if she's empowered, somebody, Mira, please mute your. Mira, please mute. Saurabh, please mute Mira Savarkar.
The problem is with me. I asked everyone to unmute.
Okay, no, sorry for that. So if the nurse is adequately empowered, she would be persistent, and she would, she would declare, okay, she would come and said, here, this is the tracheostomy kit. Should we do a tracheostomy? Doctor, should we do tracheostomy? She would ask again. And rather than, she's in the background, she's got the kit, she's left it. And actually it happened that she got the kit 2 or 3 times in that case, actually.
Correct. I agree. I just, while I completely agree to what you say, Dr. Anita, just wanted to share that there is a stepwise graded assertiveness approach that has been described, which is called as the PACE. And the PACE here stands for the first step, where, just a probing, moving on to alert, moving on to challenge, and then emergency. And I've just put up some sentences which could mean the same. So first probing is that, we have the tracheostomy tray. So do you think that tracheostomy tray would be required for this patient right now? Okay. Second step, alert, is like, objectivity, as I said. The patient's saturation is staying low. Do you think tracheostomy may help this patient now? The next step is to challenge, wherein, you are more firm about what you want to say. And this is, we have to consider tracheostomy for her as her saturation is not picking up. So there's objectivity as well as more assertiveness. And finally, emergency, that I'm calling another ENT surgeon to perform tracheostomy. Now, anyway, these sentences are related to this, but why I wanted to discuss this is that so many times there are people in the OT, like someone just said, there are residents and there are professors, and ego to the level of seniority, like Bapat sir said. So it's important that when you're a part of the team and you are and you have an important message to put through. You think the person in front of you is very senior and might feel offended if you directly give a challenging sentence. There could be a way to go about, and that I just wanted to share. May not be always relevant, but can be used in certain scenarios.
Viva, I would like to comment upon this.
So please.
Very important in this hierarchy, when you see at a challenge, people should understand that the word used is we, and that we word is very, very important. That doesn't, it satisfies the surgeon's ego, at the same time allows him to think that there's a second option available. So when we say you have to do a tracheostomy, it's like challenging his competency. But say we have to consider tracheostomy, we are on the same page and as a team. And in communication skills, this is taught which words to be used. And this we is very important. Anytime with your surgeons, you say, I think, sir, our patient needs this to be done before you induce. They will listen to you. But you said, your patient jo ABCD hai, usko ye chahiye. They will never listen. So I think that goes a long way to learn the communication skills.
Absolutely, sir. Thank you so much for this input. And now coming to the last part of the ANTS, and that's decision making. And I think it is one of the important aspects that we as anesthesiologists need to have in crisis situations, because it is a dynamic situation. It is a situation that's evolving. We have to keep identifying options that are available for us, balancing the risks versus the benefits. Like in that case, maybe they didn't consider front of the neck access because they thought it was too invasive at that point of time. But obviously, it wasn't the right decision at that time. Also important is that our decisions need to be adaptive, meaning as the scenario progresses, you might not want to consider FONA right in the beginning, but as it evolves and you realize that, even mask holding is not helping you, you have to change your decision to the next level. I just quickly wanted to highlight that the way we make decisions depends on two aspects. One, how high the risk is at that point of time and how much time is available for us to take that decision. And most of us in high risk and limited time situations would take intuitive decisions. When there is a sudden hypotension, say bradycardia, the first thing that we have been taught to do is switch off the volatile, run 100% oxygen. So some of these actions are intuitive. As the risk is lower and the time is available, these are the sequence of decision-making aids. So cognitive aid, and I'll just talk about it in my next slide. Analytical and creative decision-making is usually done only when it is a low-risk situation. However, by repeated practicing of the simulation crisis scenarios, we can use the analytical decision-making process to become intuitive. And that is the role of training, which again, we will talk about a little later. Now, we all know that cognitive aids are available. Like, I think everyone knows that this emergency manual by Stanford, which talks about all crisis situations and the algorithmic approach is available. But what I want to ask each one of you here today is that how many of you have it printed and put it in a specified location in your operating room? So we put it on the backside of our anesthesia machine, and we know that it's always there. So it's important that we do these simple acts so that they are useful whenever we land in crisis. Cognitive aids not just help decision making, they help reduce errors due to cognitive overload, and they help to promote calm and focus in crisis situations. So far, we discussed what is non-technical skills, why are they important, and the components of ANTS with examples. And now we just come to talking about the last part. Now, why? Why it is only anesthesiologists that we are talking about non-technical skills? How about others? Surgeons, nurses, other people in the OT? Well, the frameworks for non-technical skills are available for each of these. NOTS is a non-technical skill training framework for surgeons. SPLINTS, which is for scrub nurses, and AP, which is available for anesthesia assistants. And these trainings are regular in certain areas of UK. So these are available if any of us is interested in looking into the details and using them for our practice. But talking about a very important aspect, aren't non-technical skills innate? Yes, they can partly be innate. You know, some of us just have that flair of having non-technical skills. However, they are trainable, they are learnable. And like some of us mentioned earlier, simulation plays a vital role in training. However, why I have put up these brochures of different anesthesia conferences who conduct simulation-based training is that I feel this is, though it is a good thing that we are using simulation to train, it is not the best way to do. And the best way to do it is with an interprofessional team. You know, just having anesthetists all around and then doing a crisis situation is not the real life situation. What is required is that in your simulation, there needs to be someone from the surgical team, the scrub nurse, the floor boys, technicians, everyone. And this actually your own team, which will help cultivate relationships among your team that can be applied in real life. And this we achieve through something that's called as VAST. Now, VAST is a training program, simulation training program called as Vital Anesthesia Simulation Training. This is supported by WFSA, and we had brought for the first time to India in Hyderabad in 2019, and we've been associated with it since then. VAST, we only run interprofessional simulation programs, and we have scenarios which focus on the non-technical skill development more than the technical skills. So if anyone else is interested, we keep holding these training programs a couple of times in a year. If anyone is interested, you may feel free to ping me and I can share you the next workshop details. So as I said, it's important to practice simulation in your own scenario. So this is a group of our fellows and a surgical colleague. And here you see that we use iPad simulation, simple simulation software, simple. It doesn't require a simulation room or, simple things that can be used to train so that we can discuss both the technical as well as non-technical skills with the real team members. With this, I would like to summarize that we have discussed not just the importance of non-technical skills and the competence of ANS, but also the importance of training and training of interprofessional teams as we can use them in real life scenarios. Well, the topic non-technical skills can be extrapolated to other aspects of life. And I feel that a good amalgamation of both technical and non-technical skills is a perfect recipe both for clinical work and training, as well as in personal and professional life. So thank you so much for patient listening. And we're going to conduct a simulation workshop in the upcoming SOPSICON, which is the Onco Anesthesia National Conference in Chennai, Adyar in August. So if anyone is interested, please let me know. Thank you so much for patient listening. Thank you so much, everyone, for putting in your answers and also my moderators. Thank you so much.
Thank you, Dr. Vibha, for an excellent lecture or presentation on this topic, because this topic sometimes can become very drab. With those clinical examples and those videos, you really got us all engrossed. And I want chairperson's comments. Dr. Rajana Patil, sir.
Yes, congratulations. We were very crisp and very excellent presentation. इकडचं काही नाही, just on the dot, basically, with good example scenarios and everything, right? My suggestion would be not for the presentation, but what is next now, right? We know the importance of the non-technical skill and everything, right? Now, how should we go about it further now? So that will be sort of a thing to be sort of discussed, and then we can plan different simulation scenario, simulation programs, all those things. But that will be the thing of the future. So how?
Yeah. So VAST actually has simulation scenarios where the focus is on non-technical skills. And there are different scenarios wherein, so we have a scenario wherein they need to overcome hierarchy. And we see how they are able to overcome hierarchy. We have a scenario wherein there are two crises occurring at the same time, wherein your prioritization matrix comes in. So we actually have scenarios for non-technical skills. So that's what I feel. I mean, it's okay to have technical skill scenarios at the resident level. But I think beyond that, whenever we have simulations for professionals, it's very, very important that we focus on non-technical skills and how in that crisis we are able to best utilize our non-technical skills.
And I think the most important thing will be the use of multidisciplinary teams, because we always work in a team, right? Last Sunday, we did one workshop with POGS, that is Pune Obstetric and Gynec Society. So we did one scenario with amniotic fluid embolism involving obstetrician also, nursing team also, and the neonatologist. And the other scenario was PPH, right? So I think we should be doing more and more interdisciplinary simulation sort of, programs.
Definitely, sir. Thank you so much for your comments.
Thank you.
Dr. Viva, congratulations for such a lucid, very crisp and precise lecture on such a difficult topic. For me, it's more interesting, and for you, maybe because of the constraints of time, maybe you are not touched upon it, but is the transformation on the outcome of the NTS training, I mean, before and after. Are we doing any audits to that extent, the people who are trained and who are not trained, whether it really makes a difference in their performance? Because that's the whole motto of undergoing and training in NTS. And maybe you are already doing it and your center is already doing it. But in an Indian platform or in Maharashtra level, if such training is imparted, before doing the training and after doing the training, is there any significant difference? That will be very interesting to watch, isn't it?
And absolutely. But thank you for pointing that out. We have been running simulation scenarios, but we haven't really audited our work. I wonder how we audit would be how they perform in a crisis situation, is it not?
It's a very difficult task. That's what I said.
So it's a little difficult to do, but I will give it a thought and I'll see how best I can do it. Thank you so much for that input.
So for the Maharashtra office bearers and I say Maharashtra office bearers are there who are listening to you, that would be to go forward.
Yes.
Yeah. Should we start the second?
So yeah, over to Dr. Reshma.
So good evening, everyone. And thank you, Anita Madam, for inviting me for this surgical safety checklist implementation talk for the SAM symposium. And the first talk was really very interesting. And I hope I can really keep up to Dr. Naik's first talk, really. Before I start off really with the surgical safety checklist, I can see around 70 people are attending this. And I would really want to know how many of y'all really do the surgical safety checklist as part of everyday practice of all the surgeries which you anesthetize. Could we have a hands up in the meeting chat?
Hello, can I contribute?
Yeah, Sugam, please go ahead.
Yeah.
I mean, you're in Singapore, so I suppose you can't really do without the surgical safety checklist there.
Absolutely.
Yeah.
Surgical checklist is without which surgery cannot start. For obvious reasons, the surgeon has to be present. The present surgeon has to represent all the other non-present surgeons who are also going to have their cases done in that operation theater on that day. And he has to have briefed with them the day before as to what their plans are. And he will tell the anesthetist as well as nurses, the requirements for various surgeries on that day, and then the other people will also put in their input. It gets recorded and audited periodically. Then there is a monthly audit. Anesthesia chart itself has a tick box indicating that anesthesia sign in and timeout were done, without
Okay.
which the anesthesia chart cannot be uploaded into the electronic patient records.
That's great. I guess in high income countries, it is definitely a part, and you can't. And I said, obviously, in Singapore, not only the from your description, the surgical safety checklist is done, but the team briefing is done for the day. So I guess I'm really struggling to kind of introduce team brief at my hospital. In fact, the surgical safety checklist, though, we have been doing since 2009. And I would really want to know from others. I mean, have you all been doing it regularly? Because at whatever talks I've had previously about the surgical safety checklist, it's not been universally, and even bigger institute, tertiary care centers have not been doing it regularly. And so just wanted to know how are there any barriers which you all I mean face while doing the surgical safety checklist? I mean, anything at all anybody wants to share at this time? Dr. Bapat, I mean, Hinduja, I know you have been pushing for the surgical safety checklist, and you, in fact, I guess we have had discussions also prior in Tata. But
Well, let me I won't say confess, but this being recorded and this will be on the YouTube. But it's a difficult task, and even at a big good institute like us, the checklist in a real sense, I'm saying in real sense, yes, it is followed for each case, but in a real sense, it's still a long way to go. And I would love to discuss. And there are so many barriers are there, and I'm sure each and every institute will have their own cup of tea and what is missing there. At the end of your things, I think we'll open discussion and I'll share my views.
Yeah, sure. Okay, so to begin with, my topic was implementation. And so I've kind of introduced the surgical safety checklist and then gone through as how well we can implement it at our centers. So there are various checklists in anesthesia or at the hospital which we have. So we all agree that surgical safety checklist is not the only checklist we use daily, and there are central line checklists. I mean, in IC you have like a hordes of checklists. The nurses follow their own checklist. We have the intubation checklist. So yeah, so a checklist can be defined as a formal list used to identify, schedule, and kind of a various group of elements which you may not remember to do. So that's the checklist. And as Dr. Naik has already previously mentioned, the airline industry is the one which introduced all the safety things, even for our industry, that is the healthcare industry. So the history of the checklist goes way back in 1935. And this was when the Flying Fortress was taking its last flight before the American were going to sign a multi-million deal with the Boeings. So that was the last flight where they were going to sign off and then sign this deal. And unfortunately, what happened that day was, though the pilot was a very senior pilot, he forgot to, sorry, I'm just, yeah. So the pilot just forgot to disengage the elevator lock, and the Boeing crashed. And that obviously led to the first flight checklist, which came into play. And healthcare industry, being obviously has adapted this part of from the airline industry, the checklist. Now, again, this question is for you all. Do you think the patient safety during anesthesia and surgery an issue? And can we do something more to kind of make it better or make it safer? Anita, madam?
Yes, definitely. Patient safety during anesthesia and surgery is an issue, and you need to implement every part of checklist in every case because it can happen in any case. The problem can happen in any single case. You might do thousands of cases without any problem, but one case you will land up if you are not implementing the surgical safety checklist in its correct form, like
Yeah.
the wrong side, wrong drug. Yeah.
Yeah, so there can be various issues, not only the surgical safety checklist, there can be other safety like medication errors can happen. I mean, there's a lot of things which can go wrong, and the patient safety can be not taken as the way we should be during anesthesia and surgery. So I think all of us would agree that we should constantly be doing things to improve patient safety. It's not easy because it's not like it's on the forefront today that we do it. I mean, yes, we are having seminars, and Dr. Naik said she's having simulations, but how many of us are really into a whole day meetings where we are looking at how we can improve patient safety at a hospital? We do have quality managers, we have patient safety meetings, but how many of we are doing regularly things to improve the patient safety? I mean, anybody would like to share anything like how they are trying to improve patient safety at their place? Hello,
Yeah.
Dr.
So,
Rajendra.
Yeah. Yeah. Basically, in India, the practice is very varied. Okay. So there are geographical differences for the anesthesia practice I'm talking about, right?
Yeah.
But the one good thing has happened, especially in last decade, that people started talking about safety now.
Yeah.
Okay. With the turn of the century, we were struggling with the propofol, getting propofol, sevoflurane, good anesthesia machine, pulse oximetry. But especially last 5-10 years, we have been talking a lot on the safety, right? At the same time, there are these accreditation institute are coming up, right? So they are giving a different angle to the safety, right? And ultimately, it is the safety of the patient which is the prime importance as far as the, your quality of the institution or the quality improvement is concerned, right? So people are talking about safety nowadays. Only thing, the challenge will be how to implement it universally everywhere.
So,
So
sir,
that will
if
be
I
the
can
problem.
ask you, in your institute in the last 5 to 10 years, what
Yeah.
exactly things have been done to improve patient safety? I mean, have there been changes made drastically looking at kind of improving patient safety? Would you like to share what you have been kind of doing to improve patient safety? Yes, we're trying to do many things as to improve the way we anesthetize patients with various drugs, various equipments. Yes, that all happens. But are we really doing something very focused on improving patient safety?
Yeah. Basically what is happening, especially last few years, the quality department is pitching it quite well now in all the institutions. But again, this is limited to the major corporate hospital or major institution, right? But the problem remains the same as far as small nursing home is there, right? So the things can go wrong at these places, so that will be the more challenge, right? As far as safeties are concerned, the quality improvement are taking regular audits. Okay, this NABH is coming, the JCI is coming in now, so people are now more aware of safe surgery checklist and all those things, right? The challenge will be how to implement it universally everywhere.
Okay.
Yeah.
Parna, do you want to add something to that? That what in your practice have you done in the last couple of years?
yes. So as Dr. Rajendra said that with NABH and JCI, we constantly keep improving on our safety checklist. So earlier we were doing it in theater for all the patients, and we do it very religiously. So the anesthesiologist, the surgeon, and the nurse is there. When we wheel in the patient has a band on the hand, and we read out the name, date of birth, and we also address the concerns, so and specify the side if it's a knee replacement or any other operation which is site specific, then we specify that, and anesthesia concerns and patient surgical concerns, whether the blood is reserved or not, whether the ICU bed is booked or not. So everything, all the things we address at the time of sign-in. Now, in last few years, we also started implementing it in the ambulatory area, where lots of OGD scopies, the daycare patients are done. So scopies are done, and we have, say, about more than 40-50 patients a day, at times 60 or 70 patients. So lots of patients are there, and the turnover is very fast. So we
So I
started
guess, but now you
implementing that.
first implemented in the major ORs, and now you thought of implemented in the
Yes.
minor OTs, so to prevent any
Yes.
patient safety issues.
Yeah, and also we induce an induction room. So there also we call, like sometimes we give the block over there, or we give anesthesia over there, and then wheel in the patient. So even in an induction room, we started doing that. So really
So
happy.
Parna, this is just the surgical safety checklist. But
Yeah.
is there anything else in the hospital which was implemented as to improve the patient safety, say doing critical incident reporting or doing drug charts? I mean, what I mean to say is how aware are we today, as we are aware of anesthetizing with newer drugs, with newer equipments? Yes, those are very easily kind of brought in our practice, but how much time are we really giving to improving patient safety, as to getting our drug charts audited and kind of getting them better, or looking at critical incident, trying to analyze what the red flags are and so on, prescription errors? I mean, are we looking at all those? And personally, as anesthesiologists, are we really doing things other than
Yes.
I mean, sorry about this. I'm kind of trying to touch the whole this,
Yes.
not concentrating on this, because
Yes.
I really feel we could do much more to improve patient safety than just implementing the surgical safety checklist, which is really my topic today.
Yes, you're
Yes.
very right. I would like to add to that we are very strict about repeating the antibiotic to be given 60 minutes before the start of the surgery. So we are very, very strict about it, and it is audited. If the patients do not receive the repeat antibiotic in a long surgery after 4 hours, then it is red flagged. And antibiotic survey and the uh, whether the antibiotics were given or not, we are very strict
Yeah,
about
I
that.
mean, I think that is part of the NABH as well. One of the things as to do thing with NABH audit is to check the antibiotic prophylaxis within 60 minutes, whether it's given and whether it's noted down. So yes, we're trying to do it as part of our accreditation processes, but that's what, I'm sorry, I don't know why this is just...
Yeah, now we can say it.
Okay, I'm really
Yeah.
sorry about it. So
Next
coming
slide.
back, I
Yeah.
really don't know what's happening, but I'm really sorry about that. But wrong side, wrong part, and wrong patient. Have we come across all these things? I mean, I know this has been recorded and this, but do you think any incidents where if you were not doing the checklist, it would have mattered, and you could have had a different outcome to the patient that day? I mean, have you had any incidents in your hospital or which you have heard where the checklist could have made a difference? I mean,
I would like to share something at our hospital which has really helped us, and very vigilant checking of we have what is called as a second checklist for the blood component therapy form. And once when I was on call and simultaneously two patients were being operated on the emergency to the adjacent rooms, and both patients were patil. And the blood came from the storer, and it was a wrong blood which was given to another one. But just before starting the blood, we have the second check which is done by the nurse and the anesthetist. And at that point of time, it was seen that, oh my God, this Patil is something Mangesh Patil. Oh, then it was it. So it was like an event. It could have been a disastrous event which got prevented just because that protocol is in our place, and that was an emergency going at night at 2 o'clock. But still, it was practiced properly.
Yeah. So this is kind of in parallel to what a timeout does in the surgical safety checklist. A final thing before you start the main this. Now, why I brought this up is that we really feel many a times that, oh, these things don't happen at a hospital. This thing can't happen. This is very rare, and that's why surgical safety checklist is a waste of time. But and it happens in maybe LMICs like us, and it need not be happening in like tertiary care centers or so on. But that's not the truth, really. I mean, we all are familiar with Sridevi, and her mother got operated in the United States at the Sloan Kettering Cancer Center, which is obviously the leading cancer center in the US. And to the shock, basically, the surgeon carried another patient's X-ray into the OR and operated on the wrong side of Sridevi's mom. So this can happen even in a very, very developed country like the United States of America. So it can happen anywhere, anytime, and then there's nothing once the harm is already done. And just to kind of reinforce this, this is again a paper which came out in 2010, which is long time back, and which brought out in the US, where they kind of looked at 6 years of the database which was reported. It was physician self-reported database. And what they found was that over 6 years, 25 wrong patients and 107 wrong site procedures were identified during the study period. Significant harm was inflicted in 5 wrong patient procedures, which amounted for 20%, and 38 wrong site procedures. And also one patient died. So this is not uncommon. This happened in United States of America. So why was the surgical safety checklist brought in? Now, surgical safety is a serious public health issue. And because there are millions of surgeries which happen globally each year, and this is only increasing. Now, with the morbidity and mortality as high, like morbidity of 3 to 16%, and a mortality of 0.4 to 0.8%, means that at least 1 million deaths and 7 million can have complications year-wide. And this can be partly prevented if we are kind of vigilant and we use the surgical safety checklist. That's what I'm going to kind of go through. Now, this was the WHO, as part of the second Global Patient Safety Challenge, introduced the Safe Surgery, Save Life, and that kind of introduced, it had 10 essential objectives for safe surgery. So to ensure that the right patient is getting operated, right side is getting operated, and the site, it prevents harm from anesthesia administration, airways taken care of, blood loss in case is anticipated and taken care or arranged, prevention of allergic reactions, prevention and control infections, count sponges and instruments so that nothing gets left behind in the patient, identify surgical specimens, communication, which Dr. Naik has already gone through in the previous this, and surgical surveillance. So you can see these are the 10 essential things. And if you patient's perioperative journey in the hospital. So the surgical safety checklist, when it was introduced way back in 2009, it had these 19 elements. And it was like at 3 points, that is the sign in, time out, and the sign out. So it is self-explanatory that it is before induction of anesthesia is the sign in time, before skin incision as a time out, and before the patient leaves the OR is the sign out time. Now, what are the principles of the surgical safety checklist? It's a structured process. So it ensures consistency of practice, that the same safety checks are performed for every patient every time. Also, it is completed out loud by the team. So the whole team works together. So there's teamwork and there is effective communication. Everybody at the start of the procedure is introduced to each other. So everybody kind of knows the other person well. Also, it prompts for basic safety checks. So it transforms essential objectives for surgical safety into actionable items. Now, there are three key stages, now which are termed as the pause points. Now, these represent the critical moments where changes can be made before it is too late. So, before the induction of anesthesia, so at that time, you discuss the patient is awake and you discuss the patient's history and needs prior to induction of anesthesia. Before skin incision, so at that time is a timeout when ensures that all members of the surgical team have a common understanding of the patient, the plan, and any potential problem. This again comes from the industry where you kind of take a time off before you plunge into the main thing, that everything is, the stock is taken care of. So in this case, you kind of review the patient's history, you know everybody is on the same page, and then you start the surgery and before the patient leaves the OR. So this ensures that the surgical team is in agreement about the patient's condition and the post-op plan, so that the whole team is kind of on the same page. And when we shift the patient to the recovery or the ICU according to the condition, the handover which is given is same, without any confusion. Now, this is what is extremely important, which is the adaptation. The adaptation of the checklist is very much encouraged by the WHO when they kind of implemented the checklist. Now, at this point, I again want to ask people where you're using the checklist, have you been using the WHO checklist as it is with the 19 items, or you have made changes to adapt to your hospital requirements? Anita?
Yes, actually, I work in a small hospital where all the staff and surgeons I know. So we sort of skip the initial part of introduction of nurses, scrub nurses, introduction of anesthetists, introduction of surgeon, that we skip because we know each other since years. But we do all the other parts like in.
So, madam, basically, the 19-part checklist, other than the introduction, have there been any changes to which have been made to the checklist, or you're using the WHO checklist as it is on the WHO website?
We have done some changes, but I don't remember now what.
Anybody else who would like to talk about the changes, if at all, made in the checklist prior to implementing it?
So I just wanted to add, Dr. Reshma, if I could. Smile Train actually has cleft surgery specific checklists that need to be used for these cases, wherein things like throat pack and also assessing the airway has been assessed, whether it is difficult or no, or even the age and the child, the weight cutoffs that are required. So some of those things have also been included because it is specific for Smile Train to have those parameters.
So is that at your hospital?
Yeah. So they have been given to all Smile Train hospitals to be used if you do not have, say, anything else. I mean, they haven't really put it as a compulsory to use the same checklist, but they have provided a template wherein they have added additional cleft-related parameters there.
Sure. But has anybody made changes to the checklist and for the given hospital, like say pediatric hospital like yours? I guess you do a lot of pediatric surgeries, or at some other institute where they might be doing a lot of laparoscopic or robotic surgeries. Have there been any changes or adaptation done? Sugam, have there been any adaptations at your institute in Singapore?
Actually, the WHO checklist, as is being suggested, is all encompassing. All the things that you are mentioning about the surgical specific points are discussed by the senior most surgeon in charge of the list at the time of the sign-in, saying the particular requirements of the cases or that particular case. Whether that needs a robo, then the robo functioning has to be checked. The laparoscopic robotic instrument availability has to be checked, and all this will be highlighted by the surgeon himself. So that makes it
Okay.
patient
So
specific, no
basically, it's
matter
the
which case.
19-item checklist which you all are using at your
Yes,
institute.
very
And then
religiously.
you all just do the team brief, you all add things which are specific for that day.
Yes, and it is done in the specified 3 stages. Before starting the surgery, before,
The
at
incision.
the initial sign-in when the patient is not anesthetized, there is a two identifier recognition at the same time, the patient and his identity number or date of birth, which is specific. Even if there are two Patils, their birth dates are unlikely to be the same. So two identifiers usually will verify that the right patient is undergoing the surgery on the right side. Then we also will go to the second stage and uh, go through the checklist points before the skin incision. And at the end of the surgery, we will have to have a formal sign out highlighting whether the surgery done was the surgery plan. If not, then was it something different? Were there any problems? What we have in addition is something called as a dashboard, which gets flashed into the anesthesia recovery area outside. So before the patient comes out, any changes from the original plan are highlighted. It's like a airline flight, monitor. So that there are some 20 patients in the PACU, there are 20 fields, and the respective nurse can look up to the patient that she is now going to receive from the operation theater coming out to know what was different from what was planned.
Okay. Thank you, Sugam. So basically, the WHO really encourages that you adapt the surgical safety checklist to suit your hospital, but it also suggests the way it should be done, any adaptation. So when you're planning to do an adaptation, you have to test it. You have to test that whatever changes you have made to the 19 items, are they really what were are serving the purpose for what it was changed? And also a real-time feedback of the people working in the OR needs to be taken. So basically the surgeons, the anesthetists, the nurses, the technicians, so all of them need to kind of come back and tell you whether what changes were made were appropriate for the hospital, or we kind of go back and uh, go back to the surgical safety checklist items or so on. And so once that is done, I guess everybody feels that they have the leadership and the ownership of the checklist. So they kind of feel more involved in implementation of the checklist, because there is a checklist, but the most difficult part is implementing the checklist, is because people don't feel that they are involved in the implementation of the checklist. So you need champions from all the departments, like the surgery department, the anesthesia department, and the nurses and the technicians. So that is kind of very, very important, so that the checklist gets accepted and it is implemented in the right way. Also, it should be concise. You can't have like instead of the 19 things, you cannot have 90 items on the checklist, just that okay, this can be added and that can be added. That checklist is definitely going to fail, because you cannot give more than a couple of minutes at the beginning of the surgery to the checklist, and it only has the most critical and which cannot be covered by other mechanisms. Those are the ones which should be included in the checklist. So it cannot be you add a lot, or you cannot make it that short that it really not serving any purpose. So all these things, while adapting the WHO checklist, it is very important. So you have to consider that uh, while adding or removing, whether this step is at risk of being missed. Is the checklist item the best way to address the problem or need? Is this item something the team can do something about while in the OR? I mean, adding something which cannot be done, which cannot help the team in the OR, is pointless to add in the checklist which is followed in the OR. And who does this step really help? So all these things need to be uh, addressed to before making the changes to the surgical safety checklist. Now, when we introduced the WHO checklist in 2009, I mean, we had kind of champions from the surgery. We had the sister in charge, and we kind of looked at what we wanted to make changes. So instead of the 19 items, we added few which obviously I work in an onco center. So there were few items which came from the surgeons, few from the nurses, and then we kind of made all these changes before we implemented it. So the ones which you can see in the red are the changes which we made to our checklist before we started with the implementation. Also, we changed a major thing that when in 2009, that is the sign out we didn't do before we did before the closure rather than just before the patient is shifted out of the OR. So we changed the time of the sign out also we changed. So that was kind of a major change which we brought about. But we had kind of a discussion among the surgeons, anesthetists, and the nursing team to make all these changes and kind of implement it. Also, when we made these changes, we kind of implemented it in a small group. So we just implemented in one of the DMGs, that is disease management group, and we chose thoracic and orthopedic, where we implemented it. And then after successful implementation and getting feedbacks from that is when we kind of moved on to implement across all the DMGs in the main operation theater. And then we went off, as Perna said, in the other smaller minor OTs and peripheral institute. Now, this is the last checklist, in fact, which we have and we kind of review the checklist every couple of years. So just before COVID, we had added, instead of uh, the having another checklist, the COVID checklist, which was come out by the WHO and the World Federation, we added few points in our routine checklist during the COVID time. Now, this is the last checklist which we have kind of introduced, which now you can see has additional one column, which is in the OT 4 hours into surgery. So this we added specially because we do a lot of robotic and laparoscopic surgeries. So at that time, we do the second time out. And there have been a lot of robotic checklists which are also available now, but we kind of, again, took into consideration what we would like in our checklist. We started, and this is kind of yet under review. So we are kind of using it in the robotic and laparoscopic surgeries, and we will review it in 3 months after getting the feedbacks. And we're kind of filling in the Google form as to how useful we find the change in the checklist is. So as you can see, there are a lot of changes which we have kind of made, and this is after having it discussed in our OR committee, that is the operation committee, which meets once a month. And this is even after skin closure and before reversal. You can see below a row added that we again confirm instrument, sponge, needle count, because onco surgeries, being long surgeries, are very demanding where the time is concerned. There's always the nurses who change, because many of the surgeries go on well with for 6 to 8 hours, and so we have a change of staff which is happening. So kind of just to make it, and again, this is for our institute, doesn't make it being the ideal checklist for other institutes, but these are the checklists kind of how we have evolved over the years from 2009. And Prerna, this is kind of a very short checklist which we have introduced for minor OT, where we do quite a lot of DL scopies or med GI cases where they undergo scopies. So in these, the minor OTs, we just do the sign in and sign out, and we have covered what needs to be covered in the minor OT cases. So we have kind of evolved our checklist over the years from 2009 till now 2025. And whereas when WHO kind of introduced the checklist, it did so after doing a pilot study. So this pilot study was conducted in 8 countries, and 4 were high-income countries like UK, USA, Canada, and also New Zealand. And we were part of the initial pilot study in New Delhi, Tanzania, and Philippines. And what the primary outcome of the pilot study was to see whether the complication rates did come down. And this got published in New England Journal of Medicine in 2009 before they implemented the WHO checklist. So what they found was they did around 3,500 cases before the checklist was implemented. They looked at it, the complication rates and the mortality rates. And then after the implementation and education, they again looked at around more than 3,500 cases across these 8 hospitals. And what they found was that the rate of death was decreased by 1.5%. So that means the mortality decreased and the morbidity decreased from 11 to 7%. And all this was statistically significant. So was the surgical site infections and unplanned reoperations. So everything was found to be statistically significant. And this just was done before they implemented the WHO checklist in 2009. So for effective implementation, what is really needed? So this is the first part, is the extremely important part. So this is like having a team to implement. It cannot be me or you or just one person trying to implement it. It is a whole team and representation from all the surgeons, the anesthetists. They're all required for the implementation of checklist. At this time, again, I would like to ask, in your setup, do you have a team which is part of the implementation process of the surgical safety checklist, or the OR team who kind of looks into the implementation process and the compliance process? I mean, anybody who would like to talk about their experience as to how they have implemented it?
Reshma, let me put in my inputs. As far as the implementation of surgical checklist is concerned, when it was done primarily, yes, the surgeons were part of it, and along with the admin people like OT managers, the nursing in charge of the theater, anesthetist, and I was the person who was, and still since then, for last almost 16 to 18 years, I am being part of it. And there are so many difficulties what we have faced in this whole journey. And the biggest part, as you rightly said, that it should be a interested hospital staff. And what do you mean by interested hospital staff? Interest in what? Quality, safety, or the implementation or auditing? There are so many aspects of it, you know. And
most important, I think, is the belief that this works.
Well, that belief everyone has, but to translate that into reality and to work on the field or on the ground is a different ball game altogether. That's what I personally feel. And that's the crux of the matter, whether the surgical checklist is followed, implemented just to comply to the accreditation process, or in real sense, it is followed in each and every case where we are standing for that life and safety of that life, which is going to be with us during anesthesia and after surgery into either recovery or OR. If you have that empathy, sympathy, maybe in the real sense, it can be implemented. Yes, there are some colleagues and the surgeons who religiously follow it, but at the same time, it's not followed everywhere with the same intensity. To be very frank, I mean, to be very honest, if we put your heart on your hand on your heart and come out, how many of the surgeons are there when you reversed your patients in the OR, first of all? And that's why maybe you people have preponed it to the before reversal, right? Because after reversal, there is not a single soul in the OT. That's the reality. Let us face it. I'm not talking about the corporate hospitals alone. What is the happening in nursing home? I don't know. But maybe in the nursing home, the surgeon would be there because he owns the nursing home sometimes. Or maybe he has gone to the second surgery. We don't know. That's a reality, ground reality. So,
no, I
anyway,
agree with this absolutely, that just saying that you want to implement it and really the way it should be implemented, there's a vast difference. And yes, I agree that you need surgeons who are kind of ready to take the leadership roles and champions, because once when they only own it is when their registrars and fellows would really know that this has to be followed and this does make a difference. So yeah, I would say that that is the consultant surgeon would never be there at closure, but we insist that the surgeon is there till even post reversal and for the shifting of the patient. So yes, I guess that is there, but I agree. The consultant surgeon is never there at the closure time when we do the.
My simple question to Reshma, if you have tick mark that all the equipments are checked and ready to be used in the OR, how many times the tantrums are thrown in the operation theater that this is not working and that is not working? And isn't it true? I mean, you have to really speak what is the truth. And does then that surgical checklist has any value? Unless we audit it, we audit? Okay, checklist was tick marked, yes, everything is available. And in reality, it was not available.
So that was really my next question, that if at all we are implementing, how many of us are really auditing the checklist? And that is kind of, Anita madam, have you audited the checklist in your hospital or?
We do the audits necessary for NABH, like the antibiotic prophylaxis. But truly, the equipments, as Dr. Bapat said, that though it is checked and it is really checked, but still it happens that the equipment is not working. So simply we have to keep options for more equipments. Be ready with us if the equipment is malfunctioning. So we haven't audited the other aspect, not all. But
Can I just say something?
Yeah.
Yes. See, the audit, I don't know whether it will be really possible to check each and every file of the, all the patients, right? But what the quality department are doing, every now and then, they get some few files randomly. And then they make sure that they basically check the surgical checklist, whether it has been signed, date has been put, all tick marks are there or not, right? So if they find some deficiency, obviously they can talk to that particular department, whether it is nursing, whether it is surgical team, or whether it is anesthesia team.
Yeah.
So that can be done.
Let me add to this about another way of how another country does it. In our setup, we have taken the surgical safety and the checklist and auditing of it as a key performance index of the whole anesthesia, whole orthopedic, all the departments. So and our bonuses are linked to having that KPI every year after year. So if in a particular year, our benchmark of being successful 100% surgical checklist being completed and implemented does not get achieved, we lose money. A senior consultant losing bonus money, part of bonus money is a very huge amount. All of us are, that's why, forced to make it happen. Money.
Okay, I'll come down to how we have audited in our hospital. But yes, first we need a team for implementation. Then the next is that the modification of checklist. Again, this I've already spoken about, that you need to kind of make sure that whatever is needed or whatever is specific for your hospital, it is better that you kind of get those things on the checklist, and what you think was not important as part of the checklist, you can delete it, but that is after proper testing. Then next is testing the checklist through small scale testing. So you shouldn't be implementing it across the whole of the hospital, but you should be implementing it across the way we did it, kind of just did it in thoracic and orthopedic, and then implementing it across the hospital, again implementing it one of the OR locations rather than trying it out across this, because that way it leads to a better implementation. Then again, before implementation, you have to make sure everybody is aware you're implementing this. Adequate education has been done regarding the implementation before, again, the set date. And lastly, it is very important is to sustain the effective use of the checklist over time. So you can implement it and then just use it as a tick list, but it serves no better in improving patient safety. So it is very important to establish periodic sessions to reinforce use and to again look at the challenges. So as part, again, at our institute, what we do is the surgical consultant takes it during the induction, and we take it as at our induction, and the nurses again at their induction. Every year we reinforce the checklist use, and plus we have around every 6 months a reinforcement of the checklist for people who have joined midway and not at the yearly time of the joining. So for successful implementation, what I've already mentioned, that is regular education is required. Buying active leadership is extremely important. So unless you have the surgeon, the nurse in charge, or somebody from the nursing team kind of really actively involved, this is not going to work. There has to be a multidisciplinary engagement and communication. So regular, I wouldn't say that checklist needs to be looked at every month, but yes, it does need to be looked at as how you are doing with the checklist, and any feedbacks from end users, any changes which are needed, or anything which needs to helps in proper sustainability of the checklist. Again, local adaptation of checklist and accountability and support which is needed from the management. So coming back to like India, we are all talking about yes, it happens in high income countries. Now data from Indian hospitals are relatively scarce, except for few tertiary hospitals across India. Majority still either don't do the checklist or are unaware of it. And believe me, when I went to even smaller institute, they're not doing it. And even tertiary care centers are not doing it. And sometimes I get the funniest of answer, we do only the first part of checklist. And I say, oh, okay, fine. So how are you planning to get to do the other parts of checklist as well? So I guess these types of answers you get across our country, and the compliance rate is low. Now, the commonest thing what people come to us is we have a huge workload, limited staff. We are not getting enough kind of support from the management. Attitudes like, yeah, it's a kind of a real burden, adds to 5 minutes of a time, 10 minutes of a time, and the OR is lost. It just causes delay. So kind of these are all which can be worked on, and they cannot be really accepted. This is what we did at our hospital, 5 years into implementation of the checklist. So we kind of reviewed and we looked at 200 surgeries. And the way we did it was that we had a research nurse who was not part of the OR go into the OR, which was again was decided in the morning, and she observed the run of the checklist. So nobody was aware in the OR that the checklist was getting observed, and this we did over for 200 surgeries, and we looked at our compliance. And obviously, it was not good. So we kind of studied 200 surgeries, and the compliance for the first part, that is the sign-in, was great. But then again, only the interaction between the three representations were not there. That is the nursing team, the anesthesia, and the surgeons. They all were not together. The surgeon was kind of doing it with the patient most of the time. The compliance for the second part was 78%, and for the third part was 76.5%. And the one thing which we picked up, that around 6% of the items in the checklist were carried out only after being prompted during. So the checklist showed its importance. So kind of like antibiotics given, no, it was not given, and it was given at that time. So preparation for difficult airway was not done, was picked up and was done at that time. So yes, it showed that it is very important, but yes, it was found to be suboptimal. And then we kind of again reinforced it across the surgical, the anesthesia residents, consultants, and the nursing team, again, so that we can improve on. And currently, I've just finished the audit of the quality of implementation in the minor OTs, and that kind of data is yet to be analyzed. So we do conduct repeated audits just to see and come up with changes what is required. Now, there's been other study which was at Gangaram Hospital in Delhi, and what they did was they studied around 700 patients who underwent surgery, and 350 they looked at where the checklist was followed, and 350 where the checklist was not followed. And the number of high-grade complications, that is Clavin-Endo grade 3 and 4, were per patient reduced from 0.97 to 0.3, so which was statistically significant. mortality decreased in the checklist stamp, and the compliance as to the incomplete checklist, there was higher rate of complication. So not only that the checklist should be done, it should be done properly and it should be complete. So they concluded that implementation of the surgical safety checklist in a reduction of mortality as well as improved post-operative outcomes. So 10 years later, this is globally, surgical safety checklist remains a key force in global safe surgery movement. Surgical safety checklist is documented as a national standards in at least 20 countries. It does reduce the mortality and morbidity following surgery, profound qualitative impact by introducing a culture of safety, improve communication efficiency in surgical team, and also increasing patient trust. So I'm going to share this video as to how the checklist should not be done. And this is again recorded at my hospital. So you can see the surgeon is doing the checklist. The anesthesia team is doing their own things. The technician again is doing their own things. The nurse is kind of preparing the trolley. So they're really not doing the checklist the way it is supposed to be done. So they're just responding to when they are called up, but that's not how the checklist should be done. And this is how we again, and we use this as training videos for our students. So this is when obviously the way it should be done, that all the representations from all the team are present. And we don't insist that the consultant surgeon or the consultant anesthetist is there, but anyone who knows about the surgery which is going to take place should be there.
Reshma, the audio is not coming. So.
Oh, sorry. Now is it audible?
No, no.
So this is the sign-in where the surgeon is checking the consent in with the patient, and the anesthesia team and the representation from the nursing team is present. The whole part of the sign-in is gone through. So this is again the first part. The timeout, before the incident, again, there is introduction, and in fact, the nurses and the technician insist at our institute that they be called by their names and they should be introduced at the beginning of the checklist. So this is a Whipple surgery. And this is the sign out before the closure. So this is what we changed in our checklist. So here we have kind of empowered even the nurses that they don't give till the suture materials till the third part of the checklist is done and the gauze and mouth pumps are done. So that is very important because the nurses need to be empowered. So in summary, the safety of patients should always be the number one priority. And the checklist has demonstrated that even simple innovations can have profound patient safety benefits in healthcare, and harmful incidents have been avoided, and it has helped to create a safety first culture. So honestly, I really don't think that there's an excuse not to use it. And I think we should at least definitely try our level best to implement the surgical safety checklist. Thank you.
Great.
Thank you, Dr. Reshma.
I'm really sorry. I don't know why the video was not playing properly, because when I tried, it was playing properly, and it was the audio was also
Video was playing, but the audio was
audio. I don't know why it was not. But I guess the important part is that I think we all need to be involved in kind of pushing to implement the surgical safety checklist well. I mean, that is really needed, and it should be followed. Like how Sugam told that, I guess there's no other way other than to implement it, and there should not be an excuse not to use it. I guess it's shown that it is there to stay, and we should be kind of at least pushing at all our institutes to use it the right way. I mean, I know at Tata also we do face problems, but kind of we get everybody on the same board and we kind of implement it. And they're pretty, the surgeons, I mean, we do kind of do the safe OR courses. And I really feel that when you train with the surgeons, the nurses, the technicians together, that really helps out to know what the other people's concerns are also. And otherwise, we are just looking at anesthesia related concerns. But I think when you do courses like the SAFE OR and when you train with the whole OR team together, it really opens up the communication in the team. I think that it kind of really helps. And I push that in Tata Hospital by regularly having those courses.
Can I just make last comment?
Yes, sir. Please.
Yeah, basically, as far as implementation is concerned, there was a lot of resistance when the safe surgery checklist was introduced in the beginning. So what we did now, we used to put a green sheet on the operation table, OT table. Okay, and there is a big STOP written on the green sheet, right? So unless the first part of the safe surgery checklist is not done, the green sheet, nobody would take the green sheet out, right? And then everybody follows. This is what we did, and I think the time is not long enough now is here, but with this technology, I think when the patient comes to the operation theater, your operation theater door will be locked. There will be face recognition by nursing, anesthesiologist, and surgeon. So as soon as there is a face recognition, the door will open, the patient will be in, right? So most probably, this will be the thing we can do. There's going to be one app also coming of the safe surgery checklist. So we can have, so there is not much of the paperwork also. So we can do it on the tap format also.
Yeah, I agree that there is not a necessity to do it with paper. And in fact, at Tata, again, to save paper, what we're planning to do is get laminations in the OT and kind of just call it up and just record it in the EMR that the sign in, sign out, and time out, and everything was done and who was present and so on. So we kind of go paperless with the checklist as well. And I guess whatever adaptations we have done, it's taking into consideration that our surgeries are longer and we are doing a lot of laparoscopic and robotic surgeries. And I guess that doesn't really hold true for the majority of the hospitals. But being such long surgeries, we have decided even to include a second timeout, so that at 4 hours again everybody kind of otherwise you are in the dark during laparoscopic or robotic, and you really don't know any disconnections happening, any surgical emphysema developing. So all this is again taken care of. And I think again, Subham, I don't know, the robotic checklist, is it implemented in Singapore? Because in UK it is. So whenever I go to UK, I usually discuss all these things and come, and it's kind of implemented as part of the safety this in the United Kingdom.
Yeah, we have been using robots since 2004, and there is no separate checklist. We use the same checklist and make it for every surgery, including robotic surgery. So we haven't changed the format.
Okay.
Can I just comment and
Yes,
hello? Yeah.
yes.
Dr. Reshma, once again, thanks for sharing how you do it at Tata Memorial Hospital. And Rajendra, very nice and interesting input of a stop blanket or stop green sheet on the patient's not to be uncovered till the first part is done. The major hurdle I still personally feel, with the due respect of our surgical colleagues, is to harness their ego. And most of the time, the anesthetist and the nursing part is always there, but the surgeons are missing. It's a fact. Whether you accept it or no, it is a fact. Yeah. Either they are finishing the first surgery, and the second surgery, the second operation is being induced, and maybe the next lowest possible houseman or registrar will be there to do the checklist. And in reality, as like Sugam has just now put it into the chat, after the chief surgeon enters, then the whole scenario changes, the position changes, the plan changes. So that's what I personally feel. I mean, to say that the surgical checklist should be implemented thoroughly, then there are so many other confounding factors why it is not done in that real sense. And those are true, real scenarios, you know. It's not a unsafe practice or something, but that's the way you want to take a turnover of your Tata Memorial Hospital. Virtually, it will not be possible for the chief consultant surgeon to be there in each OR for each sign out. I mean, for surgeons, it's possible because they are going to put the incision. But when you do sign out, I'm 100% sure they won't be around.
No, agree, Dr. Bapat. I mean, they are not. And that's why we insist that the fellows who know and who have been throughout the whole surgery do the sign out.
For you, there may be for commando, the whole team changes from the primary headface neck to a plastic team. And at the end, none of the teams may not be around. And the combined decisions need to be taken regarding ventilation or whatever. And you are the only soul. Isn't it true? So anyway, so those are the real life situations which are little difficult to tackle. And it's a little difficult to implement surgical checklist. Even if you see your first paper, it showed the 76% of the compliance in a third part, right? Yeah. And that's a real challenge still for many hospitals to go through. I don't know how is the scenario in a single nursing home, how they do it, how they practice it, and what's the compliance. I mean, they are there. Maybe Anita can tell in the interiors of Nashik or something how they do it, and it's a big compliment if they are doing it in the true sense. Yeah.
Yeah, Reshma, please stop sharing your screen so we can have a gallery view. So it's really very challenging, Dr. Bapat, in smaller setups like ours. And you really need to be very much insistent that no, this has to happen, this has to happen. But in a true sense, it is not happening. As you said, that the chief surgeon comes and he says, no, I want this, that. So again, the position changes, then they touch the drapes. So it still happens. And but in small places, the advantage is the anesthetist has already discussed with the surgeon what is the plan, and so that is also there. You before actually the patient comes to the OR, you know the surgical plan. There are no questions in the chat because it's been a very interactive session. So everybody has put up their comments and or asked the questions all throughout both the sessions. And both lectures were very, very wonderful. I must say, Dr. Vibha and Dr. Reshma, congratulations for an excellent session. And Dr. Rajesh, shall we proceed with the vote of thanks? There are no more comments or no more questions.
Yes, definitely. I think it was a great opportunity for all of us to learn about the importance of anesthesia non-technical skills in a crisis management and a surgical safety checklist. We learned that the leadership qualities and communication skills and situational awareness are very important. And in case of surgical safety checklist, implementation always ensures critical steps to pre- prevent the errors and ensure patient safety. And its benefited surgical checklists have been shown to reduce the complication and improve patient outcome. With this, on behalf of SAMS, I would like to thank our great speakers, Dr. Vibha Naik ma'am and Reshma Ambulkar ma'am, and I'm very thankful to our expert chairperson, Dr. Rajendra Patil sir and Dr. Jitendra Bapat sir, uh, who have spared the valuable time for SAMS. And thank you for our executive team, Dr. Anita Nita ma'am, President SAMS, Dr. Avinash Bhosle sir, Dr. Saurabh Parade, Dr. Parna ma'am, and the all SAMS members who were attending the webinar. Thank you so much.
Dr. Sugam has made an interesting comment that these lectures should be held with surgeons attending. I agree. Dr. Vibha also has made an interesting comment that we should not only just implement the surgical safety checklist, but we should be secretly observing how much of it is getting implemented. Yes. So thank you everyone for attending this very important topic, and we will continue to focus on safety. And Society of Anesthesia Maharashtra State will, our theme of our webinar is Safe Anesthesia Saves Lives. So we will continue to focus on safety. Thank you, friends.
Thank you.
Thank you.
Thank you.
Thank you.
Wonderful, wonderful.
Yeah.
It was very nice. Enjoyed it. Thank
Bye.
you. Thank you both the speakers. Well done.
Bye. Bye. Nice seeing you all.
Good night, everyone.
Good night.